Very good morning. We'll start our instruction course on code RAID and VR surgeon. In our OR, we do face this code RAID situation sometimes, and this course will, all the eminent faculties will share their code RAID situations, how they have dealt with it, and we can get some tips to avoid such code RAID situation. So I welcome all the speakers on the dais. Dr. Devdulal, please join us. We have Dr. Aditya Kelkar, Dr. Somen Mondal, Dr. Devdulal Chakravarti. So without much delay, let's start the first talk. I would like to invite Dr. Somen Mondal to present his code red. So,
you can start the video from there. Yes. Okay, I'll open it. Okay, fine. Yeah, the video is not here. Okay. Yeah, and sound. Yeah, audio is there.
A 53 years old lady presented with a history of diminution of vision in the left eye for 4 years. She had a history of hysterectomy done elsewhere a year ago for macular hole in the left eye. On examination, a full thickness macular hole was noted in the left eye. Routine 25G pass planar ports made. Brilliant blue G dye was injected to stain whatever internal limiting membrane there was with two motives. One, to do a larger internal limiting membrane peel, and two, to harvest a free flap if there can be put on the hole. Even after numerous attempts, that could not be done. Finally, it was decided to go for a retinal graft. Graft area was demarcated by endodiaphragmy and surrounded by laser. Perfluorocarbon liquid was injected. An attempt was made to harvest the graft. Now the graft decides to ride on top of the perfluorocarbon liquid, and it was quite tricky to maneuver it to go underneath. Finally, after some struggle, it was managed. As you can see, the graft size is inordinately larger than the hole. A hybrid port system was being used, the right-hand cannula being a non-valved one. The graft got lost even before the mistake was realized. So, it was decided to harvest a second graft. Lesson learned this time, the size of the graft was smaller. This time, it was easier to maneuver the graft under the perfluorocarbon liquid. The graft was implanted in the hole by a silicone tipped cannula. Fluid air exchange along with removal of the perfluorocarbon liquid was done. The graft stayed in position under air. Silicon oil injection was started. To one's dismay, the graft was seen to get dislodged from the macular hole by the flow of the silicon oil. The silicon tipped cannula came to the rescue again when it was used to brush the graft back in place. The graft remained so until the end of the surgery. At the 1-week postoperative visit, the graft was seen in place, covering the macular hole snugly. At 3 months, with a good graft intake, silicon oil was removed. A week later, electroretinogram of the eye yielded satisfactory results.
Excellent presentation, Dr. Somin. Would like to know why do you think there was difficulty in peeling the ILM in this patient particularly?
I didn't get you. Can you repeat? Why?
Why was the difficulty in ILM peeling?
Okay, this is a refractory failed macular hole surgery. So the ILM had already been peeled quite a lot, and because in this is the second surgery that I'm doing, I've already done an extensive ILM peeling. So I was trying to find out remnants of ILM, which initially I tried to do a free flap. I couldn't.
Okay.
That's why I went for
Had
the
to shift back. Right.
And what went wrong in the first time when you tried to keep this graft?
So the lesson learned in this surgery is that when you are putting PFCL, you have to put much more PFCL. The PFCL has to be at least, quite an amount higher than the place where you are trying to harvest the graft from. What happened was my PFCL was smaller. I mean, the bubble was less. So when I had finally managed to take the graft from the junction, from the area where I'm harvesting from, it chose to ride above the PFCL. But if your PFCL is enough, then it will never ride. You have taken the graft and you'll have to drag it at the level of retina. You shouldn't let it go up. Now, having said that, it is also important that, like, I'm using the cutter to harvest the graft, right? So once you're using the cutter, the PFCL automatically gets aspirated. So you have to put enough PFCL so that in spite of the PFCL getting aspirated, you'll still have enough so that the level of PFCL stays higher than the level where you are harvesting the graft from.
So any particular reason you have put silicon oil instead of gas in this case?
Well, that was my first case, which I'm trying for macular hole. I wanted to be sure I don't land up with a retinal hole, retinal detachment later on. Later on, I started using gas, but in spite of that, I have right now about 18 to 20 cases. I've landed up with a RD with a bad PVR in one case.
Thank you, Dr. Mandal. Any questions for Dr. Mandal? Okay. So we move on to the next topic by Dr. Devdulal Chakraborty. Broken haptic in a glued IOL.
Sincere thanks to Dr. ANIRUDDHA MAITI for having me here this morning. So what I'll tell you
The mic is on,
yeah.
off.
Yeah. So what I'll be telling you is what not to do in a case of SFIOL and what went wrong. So let's take a look at this case. As you can see, this is a SICS tunnel that is there. This was a patient that was operated elsewhere, and so that's the tunnel. And so I don't know. There's इसको मैं कर दूं या आप करें जैसे करें so yeah So this is the video. So basically that's the tunnel that I'm showing, and this surgery was started off, with marking and marking of the 81 180 degree meridian, and the peritomy was done, and so this is the peritomy done, and next of course is the making of the flap. So that was being made, and once the flap was done, there was this remnant nucleus or epinuclear material that was there inside the vitreous cavity. So the surgeon removed the the lens contents, remaining lens contents, and the surgeon put inside the uh, forceps to hold the haptic. Now see, there's the devil inside, the air is coming out. So without proper visualization, the haptic was, the surgeon tried to hold the haptic and there was more air coming in. This often happens when you switch off the cannula and switch on the infusion cannula in between, your surgery. So this is something that is routine. Now see what happens. The haptic is, the surgeon is not sure whether the haptic is being held or not. So tentative, movements, and that is the assistant trying to show the surgeon where the haptic is. So let's see if the haptic comes out. Well, it does come out. Now, of course, the surgeon is in a happy state of mind, and the other haptic is being taken in with a that's a straight forceps that the surgeon is using, and well, the haptic could not be externalized. So you can see there's the pupil is small here, and in this push and pull, see what happens, the haptic gets broken, the iris is being pushed up by the haptic ends, and now we see some fidgety action that's going on, and so that's the haptic broken. So basically that's when the SOS comes, and the other surgeon takes over. Let's not get into details who did the first surgery and the second surgery, or rather the continuation of the surgery. So the IOL is taken out. So now you see what is the change in the surgical situation. Nothing except the air bubble is not there. So you are sure where the haptic is. You can hold the haptic and get the haptic out, and you can just put it in, tuck it in through the tunnels, and you can repose the flaps, and that's the end of the surgery. One additional tip here is that in case you are not sure, or the pupil is too small, you can always use iris retractor, iris hook, sorry, to sort of increase the area of visualization of the IOL as such, and then you can have easy access to the holding the haptic, the trailing haptic, and that's the end of the surgery. So same case in two situations. So one shouldn't be too hasty in going ahead and trying to grasp the haptic in these situations, and just be slow and patient and remove the air. Use viscoelastic liberally, ensure that the forceps have good holding, and like I mentioned, use an iris hook if necessary to have a better field of view, and see the IOL, what you are holding, and then you can go ahead. So thank you, and I would like to take the opportunity to welcome you all to the next AIOC at Kolkata. Thank you.
So very well managed, Dr. Devdulal. Do you have similar experiences if you have a broken haptic while you are doing Yaman's SFIOL or other Canabra or any other SFIOL technique that you do? And do you face similar issues, and how do you manage that?
Yeah, absolutely. I guess all of us have faced similar issues, and I think the worst offender is, like two scenarios. One is the small pupil, and I happen to do a lot of surgeries with Dr. Samar Basak, where we have a cornea that's not really clear and visualization is poor. So in such a situation, it's advisable to, in the small pupil, like I mentioned, the iris hook helps, and in a situation where the cornea is not really good, what we actually do is I do the SFIOL or the glued IOL, and he does the DMAC. So we try to peel off the epithelium, but many times it doesn't really work. So these are situations where you need to have, like, difference in the illumination that you normally use, and you can use an endo illuminator, put it inside and see where the haptic is, and somehow try and get the haptic out. I really don't do a lot of Yamani. I stick to the conventional Gabor stereoth, or modifications of the technique that are there. So and for those cases where there's a combined surgery with the cornea surgeon coming in, he prefers the Gabor stereoth technique. So that's what we do, and we don't do a lot of Yamani.
Thanks.
Thank you, Pravati. Next, we have Dr. Aditya Kelkar. He will be showing us managing intraoperatives and subretinal BFCL and subretinal oil.
Thank you. Thank you, Dr. Maiti, for including me in this instruction course. So, since we are on the topic of haptic, let me share with you about my experience of a code red situation in Yamanese AC5. So we were doing this secondary IOL implantation following the whole back dislocation here. So the bag was removed, and we are now proceeding with Yamanese AC5. First haptic is engaged into the 27 gauge needle, and then second haptic also gets in very easily, so probably I get more over enthusiastic here in trying to push more haptic into the needle so as to avoid slippage. But ultimately it so happens that the first haptic now slips out. So I was in a fix whether to let the other haptic also go in, or pull this out and then try some more acrobatics to get the other haptic. So what we decided was to get at least one haptic out, flange that. In this situation, to find this haptic under the iris becomes tricky, so I went back in, used the endolight, and with the help of forceps I have grasped this haptic now. And then you can see the angulation is extremely odd. Now to fix this lens with the help of a needle is going to be a challenge. But I didn't realize it at that point. I still went in trying to get this haptic engaged in the needle, and obviously the angle is so odd that you just can't engage it here. What we decided was to use the same trocar and use the forceps to get the haptic engaged, because angulation is not a question here, because you can at least hold on to the tip of the lens. Then withdraw the cannula and get the haptic out. Of the procedure was same as flanging the lens and then getting it back into the stereo pocket. I have another couple of videos with the permission of our chairman. Can I?
Please.
Sure. So this is another nightmare situation where we are dealing with PFCL. It's a third hand, but sometimes it can get messy as well.
Welcome home, dear friend. How long we've all been waiting. Let's create a masterpiece. Breathe life into your dreams. All you gotta do is start up the machine. You don't look like you belong here. Did you pinch yourself to see if you'd wake up from a nightmare, or could you still be asleep? I tell myself.
So we are proceeding here with a retinal detachment surgery. PFCL is being injected. I disregard this dimple sign, as you can see. So it's the force of that PFCL that is creating a small dimple on the retina. I accidentally end up injecting in the thinnest part of the retina, the fovea. The OCT confirms there is a small macular hole there, and the PFCL has gone under the fovea. So then we proceed with how we normally tackle the macular hole. ILM peeling under PFCL, and then inject some more PFCL to dislodge the PFCL towards the periphery, and through the drainage retinotomy in a retinal detachment case, this PFCL was aspirated. PFCL was then removed with the endolaser, and thankfully it had a good outcome as well. So you can use non-valve cannulas when intraocular pressure doesn't rise too high then. Also, as I said, identify this dimple sign and stop injecting. There are different ways to manage this situation. You can use the 41 days needle, have a small serous detachment, and then can dislodge the PFCL bubble. Or as I did, inject some more PFCL on the fovea and dislodge the PFCL. Also, while you are doing giant retinal care and patient has a TBR, this situation of subretinal migration of PFCL can be encountered. And so I'll demonstrate you one such situation where there was a PVR and a giant retinal tear, and after injecting the PFCL. So there is this GRT with PVR. We have tried to peel off most of the membranes, and then after that PFCL enters. This is a fluid air exchange has been done to stain the membranes first. And I wanted to peel these membranes under the PFCL because that will stabilize the retina a bit better, because it will be otherwise very difficult to peel off machine. So under PFCL we are able to get the grip on the membrane and peel them off. Most of the membranes are coming out quite okay. I use the DDMS concept to unfold the flap of the What we do here is that, of course, we have to aspirate this PFCL using the cutter. So I tilt the eyeballs slightly, as you can see, towards the side of the PFCL. As much as possible, I tilt the eyeballs and try to get the PFCL out with the help of the cutter. Once I have the major part of the PFCL out, so I get some more PFCL to stabilize the posterior fovea, and the residual PFCL is aspirated by the cutter, and I use my knife file to protect the retina from the cutter. And after that we can proceed with the remaining surgery, peeling the rest of
Any comments? Sir is here. Any comments on the last case?
You managed well. I think nothing much. I would have done same thing. Only thing previous case that I was looking at, because they took that haptic out through sclerotomy. Of course, opening is big one there.
Yeah.
The haptic to stay back in the track now, intrascleral, sometimes it's sticky. Chances of slippage are again high. But I know that's all of us face that extremely difficult situation, and that's why what we say now is like use a 2 needle. Don't get one thing out, one haptic out, and then second thing, because that angle becomes so awkward.
That's right.
So it's and in one of the cases I snapped the haptic. There was no. So that's I think a difficult situation for all of us.
Yes. Thank you.
I have probably more experience in Yamane than me. One of my patients, the same thing. I didn't realize on table everything went well. In 1 week he comes back, and what I say is, one side haptic is snapped, but like the old days, like people used to holding on, the lens is very much centrally placed. With holding on one haptic and other thing, and I can see the gap there between another haptic hanging there, because not now freely floating, but it is pupillary axis. And I told him lens has to go. Patient has refused. He says, I am happy. I don't want to do anything. Now he's holding on last 6 months or more than that. Lens is still there. I don't know how to handle now. This.
I had a similar situation, sir. There was a patient who went back happy on day one, but came back 1 week later with a haptic snapped at one end. The lens was already hanging in the vitreous cavity. So I had two options. One is to cut this flange, but I couldn't find the flange because it was intrascleral. So I had to cut the haptic and just remove the optic, leave the two haptics inside. Couldn't remove them because they were engaged in the sclerotomy. Yeah. Yeah, but I think at least the patient is happy, so we can keep a watch. Such situations are rare, but at least friendly for the patient as well as for us.
So I will play Dr. Nandi's video. He had to leave early, so I will just play his video. Sound.
A brief glimpse of hell. In this video, we discuss a challenging case of a macular hole surgery, including the inadvertent loss of an ILM flap. A 77-year-old lady presented with complaints of decreased vision in her right eye since the last 7 months. On examination, her visual acuity was found to be counting fingers 1 meter in her right eye and 6/9 in her left eye. Both her eyes were pseudophakic. IOP was found to be normal in both eyes. Her OCT revealed a large, full-thickness macular hole. A 3-port pars plana vitrectomy was planned, along with ILM peeling and inverse flap with C3F8 gas tamponade. Now, coming to the surgery, 3 25 gauge ports were made and vitrectomy initiated. After performing vitrectomy anteriorly, the posterior vitreous was stained with triamcinolone to enhance visualization. PVD was then induced with the help of the cutter, and vitrectomy completed, including that of the periphery. A few pigmented lattices noticed earlier in the inferior retina were laser barraged. A thorough 360-degree examination of the aura by scleral indentation did not reveal the presence of any other treatable lesions. Fluid-air exchange is then performed, and the internal limiting membrane is stained with brilliant blue dye. And we meet the first challenge of the case, a negatively stained epiretinal membrane, which was not very prominent or noticed on routine pre-op OCT. A flap is raised with the help of Finesse loop in the inferior arcade initially and then in the superior arcade. Peeling is then started from below the macula and extended superiorly. While trying to complete the peel temporarily, the superior edge of the hole is caught and it starts to ooze. The rest of the peel is completed despite that. While we try to peel the membrane around the macula and trim it with the cutter, the whole of the membrane comes off and we are left with nothing to create an inverse flap with, as had been previously planned. Fluid air exchange is performed again, and we restain the membranes with brilliant blue to check for the presence of ILM or ERM. The peel is extended nasally towards the disc and more peripherally. A small attachment of ILM is noted temporal to the hole, but even that bit comes off while trying to extend the peel. Superior extension of the peel was then carried out, and while doing that, we suddenly see a free floating piece of ILM floating near the posterior pole. The opportunity is grabbed with both hands to push the free floating flap into the macular hole with the help of the closed tip of the ILM forceps. And thus, for us, the day is saved. An area of inadvertent touch to the retina, which was noted, is laser. Fluid air exchange is performed again before softly tucking in the free flap one last time into the macular hole. A clot noted near the flap is removed with the Softape camera. C3F8 gas is then used for tamponade and the ports are closed, and thus we are able to overcome all the challenges that we have faced during the course of this surgery. OCT obtained 1 month postoperatively shows a closed hole, and the C3F8 gas fluid interface is visible on the accompanying fundus photo. The patient, thankfully, had recovered visual acuity of 6 by 24 and N12 in that eye at that time. Thank you.
I think this bleeding at the edge of the macular hole, it helped to close the hole also. So, any experience you use this autologous serum to close the hole in a large macular hole or any modification?
Autologous serum, no personal you experience, but sometime uh, like a atrophic, like leathery hole, something that fibrotic edges. Sometimes we just try to scratch, get those powdery stuff out, and invariably that ooze along that edge. That helps. That becomes, we want to call it autologous serum or something of blood, but that we tried intentionally. Something this, I think, this was an old technique. I mean, actually, macular hole started with all these things, Steve Charles and all those things. They intentionally used to induce bleeding there, and Bert Glesser days and all those. I think that's the way whole thing started. Probably helped that way. But I think it's now sound as like the videos so quality is so good. Actually, really appreciate like a magic carpet coming there and happily sitting down there.
In a autologous blood, I think on top of the ILM flaps, inverted ILM flap might be useful to make sure that the flap doesn't get dislodged. Rupak, you have any experience?
As sir was telling, I think that is an extra procedure, but again,
The patient was referred to me by another surgeon. On examination, there was a fake ear with redetachment under silicone oil with subretinal for.
if you can just simply
The patient was
with a
referred to
silicone
me
tip
by.
cannula, you can just simply tuck it into the hole. That is more than enough. Or even the cabbage technique of multiple layer that stays there very well, sir.
Used to extract the blood maybe half an hour, 45 minutes before surgery, send for a centrifuge, and then bring it at the end of drop of the thing. That was more for a growth factors, not to keep the flap in place. Now, a lot of people, what they will put the flap over a drop of viscoelastic to hold it on. And then Mudit was talking about putting fibrin glue also over that. but that's the extra procedure, and risk of contamination is always involved when you try to do something external procedure. That is the difficulty, I think.
Probably if it is more than 800 or 1000 micron size, even after that also, that extra procedure is worth of having it. But around 600 to 800, I don't think that again that will give you an extra benefit for that, sir.
Yeah, recently what I was looking at it, all this comparing literature with the multiple flaps or stuffing, compare that with a single flap, inverted flap, which is just covering probably much more, visual function wise. OCT closure is obviously better, but when you look at the visual function and outcome, probably they are having just single flap is better.
It's the temporal flap which is
and the classical technique of taking everything out, the best visual outcome probably again is biased because those are the smaller holes. Obviously, we are doing to you naturally expect better vision in those eyes.
One question about the temporal flap is that sometimes this flap gets unrolled. I mean, I had 2 back-to-back patients where I did a temporal flap on table, everything looks great, and then you just rolled back.
Me also. You see subsequently, again it gone back whole thing, and as if
so how do you prevent it, or
just probably little bit angle use more, so that rather than 180 degree, probably maybe 200 degrees or 210 degrees, so that the angulation is beyond that. So rather than, so the tendency to go back is less.
The visco plugging sometimes helps, putting visco over the flap.
But visco plugging, I really do not know how it is. The moment patients start moving, gas bubble moves, fluid currents are there, and it swifts back. We do not know really. So sometimes the scapulary action holding it on, well, that may hold it on, but really not. Too big a flap, chances of again it folding back are more. Just adequate or probably stay back.
how about giving the patient the position on the other side? We tend to give the patient position prone after macular surgery. With this single flap, should we give the position lateral position?
Probably to extend it may help. So maybe first day or two when a bubble is big, doesn't matter really is prone. Maybe worth thinking.
Yeah.
I'm not tried, but
another way of they do it off, like they put 1 drop of visco before putting the flap. So 1 drop of visco below and then put the flap, and then 1
sandwich
kind of technique, so that it remains the stability better. But again, these are all matter of debate key whether
I don't know whether that will work, because if you're looking at a capillary action which is holding it on an RP pump, maybe a functional RP in a macular hole area, so this negates the purpose if you have a visco sitting on the RP and then you have flap over it. Theoretically I'm talking about, I am not right.
True. But again, the mechanism of a primary hole surgery and a failed hole surgery where you are putting an ILM free flap there, these are the two different. So in case of the recurrent macular hole or failed macular hole, so it is a good idea to gently massage the margin and
the edges.
Make it little close, smaller.
I think there is various techniques described. Some surgeons prefer to give a PFCL and then mechanically scrap the edges under the PFCL. Okay, we will play another video from Dr. Sangeeta Ray. He has 2 videos. One is subretinal foreign body. Another is an broken ILM forceps.
Another surgeon.
Can we have the sound?
On examination, there was a fake ear with redetachment under silicone oil with subretinal foreign body. Silicone oil was removed and epiretinal membrane peeling was done. Inferior retinectomy was performed after cauterization at the edges. Then a trial was made to remove the foreign body, but it was not possible to avert the retina, so retinectomy was extended. The foreign body was nudged out from the subretinal space with the help of an intraocular magnet. Then the foreign body was removed from the limbus. Following which the retina was settled with PFCL and laser as done. Silicone oil injected. It started as an usual case of epiretinal membrane.
This is the second
After
case.
inducing the PVD, BBG was injected and epiretinal membrane peeling was done. It was a boggy retina. One of the prongs of the forceps was slightly bent. Then again BBG was injected for residual ILM peeling. At one point of time the forceps got stuck, so with the help of the illumination pipe a trial was made to clean the forceps, but then the forceps broke. Then with the help of a max grip forceps a trial was made to remove the broken part through a scleral port, but then it dropped. Then again one more trial was made to remove it, but it got stuck at the pars plana. On the third attempt, the broken part was removed. Air fluid exchange done and gas injected.
I think Dr. Rai was extremely lucky not to have any iatrogenic break in the retina, because this sharp foreign body might, it was treated as a foreign body only. It could have created a large break in the retina. Any comments?
Also, I think she's lucky not to have cataract, I think, because the foreign body had to be exchanged behind the clear lens with the shake hand technique, and to get it out without causing cataract or iatrogenic macular hole is itself an achievement.
I think it's the overuse of the ILM forceps maybe which caused. Okay, next.
It's a iatrogenic foreign body. So the worst part of it, if you remove the foreign body, you are removing the foreign body, but you cannot charge for that.
Actually, the surgeon had broken it. No, it's not that it's overuse. I think there was a movement like this with the light pipe.
No, actually the ILM was sticking in the one of the prongs of the ILM forceps. So she tried to remove that ILM from the with the light pipe, and that caused the breakage.
I think there should be something like how many times you should use the forceps.
I think surgeon was still lucky because it happened table and realized. I still remember long back, we have previously those back flush needle used to come with a silicone tube.
Yes. Yeah.
And then it dislodged, we realized next day.
Yeah. So I think we all use reuse the disposable instruments, and also the forceps, we all tend to reuse them. But I think there should be some kind of a stop where maybe after 10 usages you should not use the forceps, or maybe that would probably prevent these things from happening. Yeah, we usually wait till it breaks and then discard the instruments. Rather than that, maybe after 5 or 10 surgeries, you should discard them on regular basis.
I think there was a warning sign. The one of the prompts was a little bit tilted.
There was a big discussion about the sustainability in eye care. So that is how the reusability comes into that is actually, I was just listening to that Royal College of Australia and New Zealand, that session. So that is a big debate is coming up. So I mean, we need to look into it. So we'll start.
Yeah, next we have Dr. Rupa Kantiviswas, retinal detachment with subretinal blood management.
So initially, my topic was subretinal blood removal. That's what ANIRUDDHA has given to me. But I mean, to be very precise, the subretinal blood, let me before going to that, subretinal blood can be of a maybe just a dot hemorrhage to a 1 disc diameter or 2 disc diameter size to an extensive, total retinal detachment of that. So the other part which can be medically managed, like either giving cocktail regime of anti-VEGF and subretinal, the intravitreal TPA along with intravitreal gas. So that part I'm leaving it apart. So we will just deal with those who needs actually the surgical intervention to remove the subretinal blood. So this is a 70-year-old gentleman who had the other eye was absolutely fine, but this eye had a extensive hemorrhage, which is having, there is no view, and it's the whole eye is totally completely filled with blood. So here when you start the blood, I think most of them, those who have dealt with this breakthrough bleed, the easiest part is doing the vitrectomy. Because once the blood has come into this, the fibrinolytic material, they actually causes lysis of the vitreous fiber strands. And the PVDs most of the time is there. The vitrectomy becomes visualization of the blood is, the vitreous is very good because of the blood staining. So that is the most easiest part. So as you know, sorry, I could not dim this light, but this is after editing it has become a little more dim. So once you finish it, then I try to inject TPA multiple into the subretinal space in multiple quadrants. The reason is that if it is like this kind of an extensive hemorrhage, and if you inject in one area, it is very difficult to percolate to the other area. So it is not a good, it's a good idea to inject small amount into the multiple places. But again, you should not go to that maximum tolerable limit. So there is also for that, and then you wait for another typically they tell it 20 minutes. It depends upon how my list is there. So I around 10 minutes also after, then I start doing retinotomy. So but before doing retinotomy, you have to give this injection, otherwise this TPA will come out. So there is no point of giving this. So I have done the cauterization in the periphery. This takes little longer time, but this is worth of using the scissor and cut the retina precisely, so that once you are putting it back, it comes much easier instead of using a cutter. If you use cutter, there is always a tissue cut. Here you are actually incising the tissue and they are cutting the tissue. So there is a tissue gap is going to be there if you use cutter, rather than you just use it. And this is much more controlled way. You give a multiple snap and then finish it off. The chance of choroidal touch is also not here, because you have selected temporal part, which has the some amount of significant amount of the blood there. So you just, once the initial cut is there, then you put the flap back. And yeah, this is the most important part, which I got caught here, is the RPE. So retinal pigment epithelium, along with the blood, the pigment epithelium which is lying under this is very difficult. I'll just stop it here for a second. So here the most important part is that you are dealing with a liquid blood, you are dealing with a clot, and you are dealing with RPE. And in the other side, the flap is there. So there are multiple, you need to understand here the fluidics of that. So your fluid should come in such a way so that the flap does not go much more flattering. And your fluid, first it is good idea either with the cutter or with your float needle, it take out the liquid blood first, and then handle the clot. And during the handling the clot, the most difficult part is handling RPE, retinal pigment epithelium at this, because this is completely adherent at that area. So my suggestion is that if you are leaving some amount of the clot in the peripheral area, you can leave it, but try to preserve as much as RPE as possible. So I'll show you at the end how it has landed up. So, oh, sorry. Oh. So once you finish it off, all the blood you remove completely. This is yeah, this is there's a RPE and there's a clot what you are taking care of it slowly. Otherwise, another option is that you just take it in front of the retina and then slowly chew it up, or you can use as a foreign body, and then sometimes it is so fibrous that it is difficult to take out. And then you put the flap back and PFCL, the rest of the part is very routine procedure. So put the flap back, endolaser, under silicone oil, under PFCL you do endolaser and then direct silicone oil exchange. So this is the post-operative after 7 days. So you can see that extensive here, even with the utmost precaution also, I could not save the extensive part. But I was very lucky to preserve the subfoveal area of RPE. So the patient had a nasal scotoma, but still the patient had a significant good amount of the vision because of the subfoveal RPE is preserved. This is the other eye picture, and this is the OCT at the end of the surgery after 6 weeks. So this is just to open for the discussion, and I invite all of you for AIOC2024 to Kolkata, and please come and stay with us in the city of joy. Is yet to come up. Yet to come up.
First week of June. We don't know the exact dates. Dr. Rupak, like in the last case, is there an option of the choroidal patch, because as you said that area was diseased?
See, again, this is a choroidal patch because once the blood is, subretinal blood is there, and the other part of the RPE is not that vitalized. So it is try to preserve the RPE during surgery. It is much more easier rather than taking a choroidal graft or the RPE graft from the other area. Because in that situation, again, you need to go to you need to preserve it. You are dealing in the temporal part. So again, you need to go to the nasal part to harvest that RPE. So you need to cut the retina again to the, extend the, your retinotomy site to the nasal area, and then harvest RPE from there. Yes, it is possible, but again, it is much easier, to take care of the RPE. So if you keep it in your mind that yes, RPE I should not chew up the RPE along with once you are taking up the, clot, especially. So this is most important.
So I will come to a very basic question. When do you plan an subretinal TPA with the gas to dislodge a subretinal hemorrhage, and when do you plan this extensive operation? Because nowadays with the subretinal TPA and the tampon, the results are pretty good actually.
That's what in the initial phase, before starting the talk only, I was just describing. So up to 2 to 3 days diameter of blood, and if we can measure the amount of the blood is up to, I think sir can guide us,
the thickness of the blood is also important.
Yeah, thickness of the blood. So up to, if we can measure up to around 150 to 200 of micron size. So grossly is up to the retinal, or maximum up to the retinal thickness of the blood. So, and diameter wise around 2 to 3 Ds diameter, this amount of the blood can be tolerated. But yes, not tolerated, this can be handled medically kind of, or a conservative way. Probably if it is in the subfoveal area, so I will definitely prefer for doing gas tamponade along with that. And if it is in the away from the fovea, so probably just anti-VEGF injection and further investigation accordingly.
Do you inject the TPA using a special Med1 cannula?
No, this is normal one. TPA, it comes in a vial. So you inject 19 ml of water for injection, and then dilute it, and from there you take. You need to use it of 0.5, maximum of 0.5. If you go to the multiple places,
the dose is 10 to 50 microns.
Yeah, 10 to 50 micron in total.
In total.
Okay, so how do you
microgram.
inject only that
That
much
is
amount?
with a 1 ml syringe and 41 gauge or 38 gauge cannula.
Thank you.
Sir, your experience?
I don't think I would have done anything different. But yes, even TPA nowadays, what you have enough evidence, you do not need TPA. Also, whether it is just gas bubble versus TPA and gas bubble, I think more or less results are good. The why smaller bubble, because
That is for conservative way you are talking about, for conservative management.
conservative management. Yeah, but because and for that, what you are talking about is when you put a gas bubble, you need to have enough space around that bubble that clot should get pushed, and that is what logic why you look at a smaller clot. But like what you have here, there's no place, nothing moves around because there's so much of blood here. So unless you go physically remove it, but again, all these cases already contracted blood, most of the RP is already gone. Chloride also sometimes become just leathery. Yeah, I mean, I would say congratulations and that you got a lucky good results. And what we again look at it, these eyes with this blood, some amount of blood is always left. So much of manipulation subretinal, they come back with a subretinal proliferation more than a pre-retinal proliferation. So recurrence is very high. So we can do as clean job as possible. That's best we can do and hope for our best.
Is there a role of pre-treatment like we do in some diabetic vitrectomies? You give anti-VEGF 3 or 4 days prior. So similarly, is there a role of giving RTPA 1 day prior to doing this kind of a surgery just to make sure that the blood is lysed and removal will be easy?
Actually, that is by the two-stage treatment. Actually, that works. Like you give like a TPA, maybe let the patient be supine previous 24 hours later or something. Most of the time, 10 minutes waiting does not work because of huge clot, small things. So ideal time should be 45 minutes, but you inject and wait 45 minutes practically may not be possible also. That used to like put the inject, wait, get something done and come back again. And most of cases when you are doing under local anesthesia, again is not practical. So easier way, what you are saying is probably now best way. Inject previous day apparently is as good as, and you don't have to go in a subretinal space. Vitreous cavity you inject and take for an next day.
And in fact, planning for this is very important. What actually we have learned from sir, all the cases sir used to, when we are doing our fellowship, I'm just sharing, our fellowship days. Sir used to ask us, whenever you go start for the surgery, what is your plan? So this is very important. I think especially you cannot have the ad hoc plan key. If this is, yes, you can have the plan B in your mind, but you have to have the plan A. You cannot go and decide on table whatever I'll see. So that's what the initial ultrasonography by yourself is one of the, or somebody whom you can definitely rely upon. That ultrasonography is important here because how much liquefaction of blood is there, where exactly the PVD is completely is there or not, and the retinal detachment surgery associated with any other suprachoroidal hemorrhage also, because yes, this PCV can lead to some amount of the suprachoroidal blood sometime. So these are the important issues which you need to know earlier. But again, anti-VEGF, I don't think that having any role in this kind of situation, because again that is a waste, because anti-VEGF you are not going to work there for at least for a month time. So by doing vitrectomy again it will get washed out. So maybe at the end you can put, but again under the silicone oil there is a matter of doubt.
I think we give anti-VEGF when we are planning for this intravitreal TPA, anti-VEGF injection as well as gas. We are not planning for a subretinal surgery, or rather we are not
That
planning
is for
for a
the medical
vitrectomy.
management. Yeah, just one more point, how Dr. Himadri was asking. So one point is that another is to deal with anterior in front of the retina. Other way of dealing it is the cocktail in the subretinal space. So there you can give some TPA, anti-VEGF, and a small bubble of air. So, but here you need to remember that ask the patient not to be in the supine position in this. Most of the time sitting position, so that sitting or maybe in some lateral position. Otherwise, the bubble can come up to the fovea and causes rupture of the fovea, and you can land up of having a macular hole. There are multiple examples are there. So especially when the PVD is still attached in the foveal area, so that you can land up of having it.
So I will be showing two code red situation. Can we have the sound? So the first case, this is a non-resolving vitreous hemorrhage, pretty simple case. As you can see, there's a thick, dense vitreous hemorrhage. While removing the dense hemorrhage, we saw the underneath there's a well circumscribed ILM, sub-ILM bleeding. Not a difficult thing to treat, and generally the results are pretty well. Trimming the base, looking for any residual vitreous. Now this patient starts coughing, so I had to explain her, and in between the cough period I was peeling. So the intention was to remove this ILM, clear off the blood, and quickly close. Because once we remove this sub-ILM bleeding, our work is almost done. As you can see, after the ILM peeling, the bleeding dislodging. But there was quite thick blood in the periphery, so decided to trim it quickly and come out. Now that the problem started, the patient was coughing continuously, almost 5 to 7 minutes. She was sitting on the table with all the cannula and all the stuffs inside. So in fact, if you see this, there was a valve cannula was actually leaking a bit, and the streak of blood which came out from the cannula itself, it was bleeding very badly. So next time when I went inside to see what has happened after the bout of cough, it was a suprachoroidal hemorrhage, 360-degree, and in fact getting inside from that port was very difficult. You had to manipulate through the suprachoroidal hemorrhage, induced superior artery, and now the situation become very bad, and it is always very difficult to remove the freshly bled rather than removing an organized blood. You can see after fighting for 15-20 minutes, we were able to remove all the bleeding. Once the bleeding was done, then we need to address the suprachoroidal hemorrhage as well as the RT which has been caused iatrogenically. Did a fluid air exchange because I had to identify the area of break and do a cryo, because doing a laser at that area was very difficult. Put an oil as well. You can see this is 360-degree suprachoroidal hemorrhage is there. Did laser 360 on the other side and did cryo as well. But the patient was lucky and I was also lucky. It came out to be pretty good. This is like after 3 weeks, the vision is 612. Yes, it is on oil, but the suprachoroidal hemorrhage is actually subsided and the RT is well settled. So coming to the second case, trauma is always a challenge in the code red situation. You can get anything inside, all unexpected things. Let me give an history. This trauma happened due to the fan fell down on his head and injured the eye as well. So when he came to us, there was total hyphema, absolutely hypertonous eye. In fact, USG we did a little bit, but obviously being an open globe rupture, we could not do it properly. So let's see, it was like decided, we will see, we will explore the wound, we will close the wound, and then have a peep inside and see what needs to be done, whether we need to do a 2-stage operation or a 1-stage operation. So we started exploring, and this is the tear which we got. But this tear was extending behind the insertion of the muscles, so we had to disinsert the rectus muscle. Luckily, I had my pediatric ophthalmologist colleague. I asked her to disinsert the muscle so that we can have a proper exposure of the wound and secured the wound first. Now you can see this is the extent of the globe rupture behind the muscle. So once we secured and the muscle was reinserted, we plan to take out the blood which is there in the anterior chamber. The hyphema was drained, thick clotted blood. After that, we decided to go inside and see what's there. Actually, it was a thick vitreous hemorrhage, suprachoroidal hemorrhage, as well as retinal detachment. It was impossible to, without removing the lens, it was very difficult to approach this case. So we thought we will remove this lens and then go inside. Yes, the option of two-stage operation was there, but there was a total detachment. Already the patient had come after 7 days because there was some stitch given in the general hospital. So I thought, okay, let's go it in a one-step surgery. After removing the lens, put an AC maintainer. Now we can see a little bit of retina, not the retina, I would say the detached retina with a choroidal rupture and suprachoroidal hemorrhage. The vitreous hemorrhage was also very difficult to remove. So with a lot of patience, we gradually removed the hemorrhage because we had to remove this, we had to get the posterior highlight phase, remove it before we inject NPFCL. Now the plane is nicely identified, and from the surface of the retina we cleared all the hemorrhage in the posterior pole at least. And once the posterior pole was cleaned, put some PFCL. You can see the choroidal rupture area. Now putting the PFCL, at least the posterior pole was stabilized and the periphery was taken care. And did a rigorous laser in the break area as well as 360-degree because the visibility was not that great and the suprachoroidal hemorrhage was also there. So ultimately after 2.5 hours we could actually settle the retina, address the suprachoroidal hemorrhage to some extent and repair the globe rupture. And this patient was extremely happy. This is, I will show you the picture after 3 weeks. From perception of light, this patient gained 624. This is the post-op picture, the anterior segment and the posterior segment. Thank you.
Challenging situation, no doubt about it. This is the first case was actually is not in anybody's control.
First case you can't help it.
Yeah.
Situation like this can arise on table.
And, I was just thinking of that. What was the initial cause of blood and the sub-ileum bleeding?
The first case. First case was a diabetic patient, uncontrolled diabetic and hypertensive patient. But looking into the type of the bleeding which has happened, it can only happen in a ruptured ram, because bleeding in all layers, either it has to be a PCV or a ram. In a diabetic patient, generally doesn't happen like this. So most likely it was a ruptured ram.
but we could not see
No,
any evidence in that
no,
way.
no, not
so now
really.
retrospectively, I was thinking whether it is a Valsalva which can have a sub
Actually,
violent bleed and
after
the
this operation, we had taken a lot of history, blood thinners, or in any case, we take a history. So there was no significant history which we could explain this exact etiology of this first case. But she was a diabetic as well as an hypertensive. Yeah, I told you this was an option. But when we see a total detachment with suprachoroidal hemorrhage, and it was not just a day before the injury happened. This patient had gone to a general hospital because he had a huge cut mark in the forehead. They repaired it, but they were not doing anything about the eye wound. So this patient actually had come after 7 to 10 days. So it's not like it's a very fresh case where we operated in the first go. But yes, it was in a first sitting. Yeah, yeah. I showed it was a through and through. It was almost 6 to 9 rupture was there. So with this, I think, yeah. Yeah, it was an iatrogenic break, and there was 360-degree choroidal hemorrhage. Yes, I could have done the laser only to that area if I was pretty much sure that that is the area, because that time it was very difficult to identify the exact location of the break. Obviously, we had done a cryo over there, but I didn't take a chance. I did a 360. There's no harm if it's a mild burn. No, this patient was sitting up. If the cannula had turned, it would have been a choroidal serous choroidal detachment, but it was a suprachoroidal hemorrhage, and maybe the hypotony actually induced it. Okay, I think our time is almost over with this. I would like to thank all the co-instructors and all the delegates who participated. Thanks for attending.